This is PopHealth Week, streaming live on Healthcare Now Radio. I'm Greg Masters, your co-host and executive producer. Joining me in the virtual studio is my partner and co-founder, Fred Goldstein, principal host and president at Accountable Health, LLC. PopHealth Week is where we cut through the noise and get real about what's working and what's not in population health. Whether you're a payer, provider, patient vendor, employer, or policymaker, you're in the right place for practical insight and grounded experience-based perspectives. Want to stay connected? Find us at popupstudio.productions. Message me on Twitter via @GregMastersMPH, and that's Greg with 2 G's. And do follow the show at PopHealth Week. To reach Fred direct, go to www.accountablehealthllc.com. Today, we're honored to welcome Dr. David Wang, Executive Vice President for Value-Based Care at IKS Health, a value-based care enablement company. This is a second in a series featuring the clinical brain trust at IKS Health. The first kicked off with the Chief Medical Officer at IKS Health, Dr. Grace Terrell. David brings a rare blend of clinical depth and operational firepower. He's led palliative care transformation at Scripps Health here in San Diego, run plant operations as Chief Operating Officer at Mass Advantage, a provider-owned health plan, and now at IKS Health, where he's working to help clinician enterprises actually succeed under risk-based payment models. With 75 peer-reviewed publications and a track record of building care models designed for global capitation, David is both a practitioner and thought leader in complex care and population health. We'll dive into what it really takes to operationalize value-based care at scale, not just theory, but execution, the accountability, and the infrastructure that makes it stick. So, Fred, the mic is yours.
Thanks so much, Greg. And David, welcome to PopHealth Week.
I'm glad to be here. Thanks for having me, Fred.
It's a pleasure to get you on. I'm really looking forward to today's conversation. Why don't we begin? Give us a little sense of your background.
I've really enjoyed wearing a few different hats in healthcare. I'm a practicing physician. My background is in emergency medicine and palliative care. I like to think I've cared for a lot of folks who've fallen through the cracks in their healthcare journey. Was also a management consultant, a builder of many value-based care programs, which took me in a foray into the health plan world. I worked at a payvider Medicare Advantage plan, led that as Chief Medical and Chief Operating Officer, and just had a great experience helping to bring providers into risk and succeeding in value, and ultimately landed at IKS a couple of years ago.
That's really fantastic because it gives you these unique different lenses to look at the system on as you look at how do you kind of improve it and seek to improve it. So thinking about that and your background, how should we be looking at this changing landscape of value-based care?
Healthcare is very complex. I will say often when I'm in any station in life, I've been in one camp and we point to other parties, payers, pharmaceuticals, the business side, or clinicians who don't want to change, and we often demonize them. And what I found is it's rarely that simple. In healthcare, we are rife with principal agent problems. We constantly are trying to maneuver within the iron triangle of healthcare, the challenge between cost, access, and quality. And trying to succeed under that, it's very difficult. The people who work hard in the American industry, they are our neighbors, sometimes even our own family and loved ones. We're all trying to do best, and we all think that we are propelling health forward, often at the expense of someone else. What I think is different in the last couple of years, and we may be reaching a tipping point, is we really are more of a convergence now. Healthcare has ballooned to an unsustainable amount of national spending, and that has put a lot of pressure on how we decide we want to finance healthcare and what we want to incentivize within that. And with the compressing margins from that across the board of doing more with less, coupled with the rising expectations of what patients' experience should be and how do we meet that, I think that has forced an innovation onto the doorstep of a lot of organizations that have been happily incumbent in their small mountains in our industry.
And so as these different groups look at it, you talk about this convergence. How do you see that coming together? Are there certain structures that create that or certain financing mechanisms that incent that behavior?
I think CMS is at the tip of the spear there. Both the plurality of models they tested under the prior administration, and now the real condensing and simplification with what we're seeing now. There have been learnings through REACH, through the Maryland pay model, that now are, I think, being baked and expanded out into the new next generation of payment mechanisms. Incentives, as everyone on this podcast can appreciate, are a significant driver in how we respond to and innovate our care delivery structures and organizations around how to meet that need and take advantage of the momentum in the industry.
So you've mentioned them. Obviously, CMS has put out a lot of models, David, and they tried a lot of different things. But you mentioned the Maryland model. Could you discuss that a little bit and why that sort of resonates?
It was a bold undertaking to take all of the payments, all the hospital-based payments in the state of Maryland, and bring them together, kind of circumvent some of the variable pricing and the distorted incentives of perhaps patient selections between hospitals in that state. My understanding of it is it did contain cost growth, and I see it in a time when costs were growing even higher. And so a tremendous undertaking to be able to coordinate across parties for that. And I'd love to see kind of the continued expansion of that. I do believe there's some movement recently with a couple states in that direction. And I'd love to see kind of where else that can take us.
It's really a fascinating model. Let's go down to the care delivery organization. I mean, where the rubber meets the road. You know, per se, you as a physician, how should these care delivery organizations of whatever type be thinking about succeeding in a value-based world?
In my mind, Fred, value-based care really is it's a duet. It's a duet between having the right incentives in place and affecting the right change management to take advantage of those. The incentives are key. I think it's Upton Sinclair that famously said, it's really hard to get a man to understand something if his salary depends on not understanding it. Much of healthcare is like that. You know, we are, especially the delivery of healthcare is very much an apprenticeship-based model. If you spent your whole life blacksmithing in a certain way, and then someone came around and said, I really want you to do it this other way, it's very difficult to be able to exceed the inertia and the disdain to move in that direction. And so getting the right payment structures in place with the right amount of risk in time is key for any care delivery organization moving in that direction. So starting with contracts, understanding your network is pivotal. But I can't also understate how important it is to think about what their readiness is in terms of change management. If an organization has largely been sitting in pay for performance contracts or in one-sided risk, moving into two-sided risk is a much more nuanced conversation, and that requires quite a bit of navel gazing to understand how their clinicians are prepared for that.
And, you know, I would think as you think about this too, and you look at a practice, it's not just the physician within that practice and the change around that, but it really impacts all of the players in that group, right? And so being able to provide, whether it's the back end for that or the change management for that, is a critical piece of making that movement.
100%. It's, you know, I think where some care delivery organizations have fallen short is thinking, you know, the numbers are very enticing on, especially if you're entering into capitation and a huge amount of revenues coming in. But let us not forget, it's called risk for a reason. It's not called free lunch. And so can you contain the amount of expenditure coming out in a way that does not in any way compromise the patient experience or outcomes? So to your point, Fred, how do you make it a team sport? How do you get everyone on board? Your pharmacists are going to be a key part of this, your MAs, your office managers, in addition to the ones who ultimately own the final click, the order, which are the physicians and the APPs. When I think about that, I think one of the greatest elements of hubris that we sometimes fall prey to is we think that we can engineer change through protocols or through moving lines around on an org chart. And as anyone who's walked a mile in the shoes, you know, it's incredibly more complicated than that. And ultimately, change happens at the speed of trust in organizations. And no matter what edicts or protocols you may push through, ultimately your end user clinicians are going to look to the person to their left and to their right and take more from their feedback than from any specific mandate given to them. And so how do you create these nodes of change within an organization that can drive that positive momentum, be on the upside of the Losada line to really move you in the direction of the behavior you'd like to really take root in your CDO.
Yeah, and I think too about it, as a population health person, I think, population health essentially is built upon a layer of data, and a river of data flows through it, and ensuring that that data gets to who needs it in a way they can use it. And that's sort of been one of the difficulties we've faced, I think, is thoroughly ingesting that out throughout the system, or creating it so that the system can make it functional in a way, as you said, to change the behavior.
Absolutely. And data and tools and resources are key. Anytime a CDO is moving into risk, really at the heart of it, once you get your incentives all set and baked, is how do you manage that complex change to get there? How do you make sure you have not just the right data platform and tools, but how do you ensure your workforce is appropriately skilled correctly? And you have an action plan in place. I like the Noster model for complex change. It's probably a few decades old at this point, but it has time and time again proven to be the recipe for how do you maneuver complex change and navigate it in a big organization and enterprise. When we don't have the right plan in place with the folks on the ground using these tools, if you just kind of drop ship in a fancy data platform with all the bells and whistles, you significantly run into the risk of creating false starts or creating anxiety because they don't know what to do with it. Maybe they are excited for it. How do they actually make that change sustainable? And then what are the downstream kind of interdependencies, and whom else does it depend on to be useful?
You had mentioned the term CDO. Could you define that for our audience?
Oh, apologies. Care delivery organization, which these days can run the gamut from your usual hospital-based health system to medical groups, single or multi-specialty, to things that now live in the middle, community-based care models that are funded through a variety of mechanisms, or convener models. I would say the various interfaces that try to bring people who want to deliver good care to the people receiving the care.
When we talk about risk and managing risk, whether it's global capitation or up and downside risk or bundles, are there various differences that organizations should consider in that, or is all risk sort of looked at the same?
Certainly not. I think that would be a dangerous path to go down, is treating all risk as the same. I think that the traditional path has been starting in pay for performance and then moving into gain sharing or one-sided risk arrangements, and then eventually into a shared savings and then capitation model. I think we're seeing more organizations, especially within the specialty space, be more risk-loving and wanting to move more quickly into that. Folks who've learned a bit of what it means to manage total cost of care and proactively identify rising risk, while also not losing sight of your revenue levers and risk coding and quality, and take a bigger size bite from the get-go. I do think with the advent of technology and all of our AI-enabled tools now, we are able to have greater line of sight into the performance of risk. And so, whereas in the past, if a CDO said, "I want to jump quickly into two-side," I would say that's putting the cart before the horse. At nowadays, I'm not so sure. I do think with the right kind of arrangement, if you were able to engineer that change in your organization and set it up to be a learning organization and be thoughtful about your contracts, it is possible to accelerate into risk.
And is there a difference in thinking? You mentioned the specialists, and they're going obviously into risk pretty quickly. We've also seen some fairly effective and efficient primary care practices do global cap or things like that. Where do you think that line sort of falls now in terms of movement to risk?
I think it takes a village. As somebody who's been a proponent of value-based care, I welcome all efforts in this space. I think certain high-spend specialties in which there are significant amount of variance in the delivery of care without a corresponding variance in the outcomes, that is sometimes called inefficiency. I think there's opportunity there to bring a value-minded mindset to that. And I appreciate the efforts that are underway within musculoskeletal and nephrology, and excited for what's to come in cardiology and other spaces. I still am a believer that whomever is the quarterback of care ultimately has the greatest ability to impact this. And that to me is still the primary care provider.
Mhm.
We've seen various iterations of that over the years, the medical homes and such. And even now, though, I think with how your average American receives care, they still need a quarterback. Most of us are not, when we enter a time where we become greater utilizers of healthcare, we know we generally aren't single morbid condition consumers. We generally have a litany of issues, and that creates a lot of interdependency across the medical care, the pharmacologic management, and then the things that often get left behind, like behavioral health and social determinants of health.
Just tuning in, you're listening to PopHealth Week on Healthcare Now Radio. I'm Greg Masters, co-host and executive producer, here with principal host Fred Goldstein. Today we're joined by Dr. David Wang, Executive Vice President of Value-Based Care at IKS Health. Stay tuned. There are more insights ahead.
So, David, as you think about this from these different groups, different physician types, et cetera, what are the challenges? You mentioned variation. You mentioned the issue of data, but what are the challenges being faced by these practitioners or physicians and other clinicians?
I think we're shifting from a conversation of what used to be why, and now into a conversation of how. I think NACO's put out a survey recently that said 2/3 of the enterprises within their coalition are expecting to see more revenue coming from VBC. I think even as early as 5 years ago, the number of hospital-based health systems that had more than 10% of their revenue coming from risk was exceedingly low. And now there's many more, and trying to move into the tipping point of north of 20%. So it's happening. Sometimes I think it's happening against their will because of how the carriers are sharing in the risk imposed upon them to their care delivery partners. So if this is the reality we're in now, whether you're excited for it or you've come along for the ride, how are you actually going to execute on it? There are a litany of value-based care solutions out there. And in this day and age where you can vibe code anything, it's probably maybe a solution a minute that's popping into the marketplace. But in my eyes, and as somebody who's used some of these tools, it's not about what has the greatest bells and whistles. It's about what's actually going to be sustainable, what's actually going to be sticky. And ultimately, those are the simple things. The simple things are the ones that will have the greatest adoption. And what makes something simple? It's if there are people within these organizations implementing them and bringing them into the maximum possible impact. That's one thing that we try to do at IKS, which is we're not just bringing you something that looks akin to the many value-based care solutions on the market. It's not just an AI first solution. In fact, we believe strongly that humans should be at the helm of any AI enabled service. But then we actually spend time to walk the halls with our partners and act as operating partners in a way to drive some of those change management initiatives to make sure that what we're actually bringing is actually leading to value creation for them. It's not a set it and forget it scenario as we all remember from the 90s. None of value-based care really can be executed in that way. Ultimately, you must meet people, your clinicians, where they are to create the trust to be able to bring about that change.
And you mentioned AI. Obviously, it's the hot button item right now. I think probably every booth at HIMSS had AI on it, in a sense, kind of like population health 5 years ago. And so you also talked about, it's interesting because most people say, oh, yes, we have a human in the loop. But you mentioned sort of overseeing the loop in a sense from a person being involved in it. Can you discuss that a bit?
Yes, I think, I don't know from a legal or ethical standpoint yet where the industry has moved towards allowing AI to autonomously influence care more and more. I won't say outright, practice medicine, but we're really kind of abutting against the edge of that. And I sometimes think about, in the future world where we all ourselves require more care, how much of that will be based on the human interaction that is such a pivotal part in understanding what is both said and unsaid in a provider-patient interaction, and then understanding the non-regression based factors that can actually lead to a care decision. There is, in my opinion, a boom of healthcare utilization that is coming from the AI revolution. You, our listeners today may be familiar with Jevons paradox and the notion that AI actually perhaps won't decrease costs, but may actually increase net costs in healthcare because the barrier to entry of receiving care is much lower. And to me, that is a good thing. We've democratized access, enabled an experience that before was very difficult to scale, especially if you were not somebody who lived in the right place at the right time. But with that, then we have to be mindful about what does that mean in terms of the total size of the pie, and how do those shifts then affect our care delivery organizations? What are the staffing models to achieve that? And as humans enter into more of an audit and oversight of that, how do we really ensure we have the vigilance for that? For my organization, we take that very seriously. The AI is not a practitioner. It is there to execute and handle rote tasks that are generally of lower cognition, and also to be a first pass at gleaning insights that normally otherwise would have required a lot of data mining. Smart business intelligence, but we're not the ultimate decider on anything.
Mm-hmm. You mentioned a fascinating piece there that AI may create more cost, which actually would be better, as you talked about. It's getting more people access. It's getting the disadvantaged populations in for care they couldn't get, et cetera. At the same time, obviously, these clinics and physicians, et cetera, are facing margin pressure, workforce shortages, and burnout. Do you see sort of the AI taking away some of that to allow for this increase in utilization?
Absolutely. And, I think the age-old saying is you're practicing at the top of your license. And I do think that with a lot of the broader platform of what organizations like IKS and certainly other enablement companies can do is help move everyone outside of any of the clerical duties of healthcare into the human relation based parts of the job, which for me as a practicing physician, I enjoy most. And reduces a lot of the time spent at the end of the day to catch up. I think on the normal bell curve of clerical duties, probably 20% of your average clinicians can handle those very quickly and get home on time. And then the remaining, and then there's 20% who are consistently behind and earn the ire of their managers. And then the middle are just struggling to make it work. They love the parts of the job. But then they also wish that they didn't have to spend time clicking around on a screen or signing things by paper or wondering, why can't I find something that normally should be a part of the chart, but is on a loose leaf paper on a Post-it hanging around somewhere attached to somebody else's computer. And I think these are the things that we can solve for and should. And part of what IKS Health as an organization is driving towards, which is restoring a lot of the joy of what brought clinicians into their work and preserving that, because even as expectations are rising for consumers, the experience is eroding for clinicians. And we need these folks. We are at a shortage. We need people with courageous hearts to stay in the fields they're in, to care for us when we all age and need more care.
Yeah, and I think your point about joy is really critical, because not only is that an impact on the individual themselves or the clinician who's, feeling so stressed out from their work, but it's also an impact on their ability to then relate to the patient and understand what they're doing and focus on that. So it sounds like at IKS you're thinking about this. You talk about walking the halls with them to build those systems that make it a little easier to practice and provide the data you need to then make better decisions.
That's right. Yes. Tools to alleviate the pain felt by all members of the greater healthcare team, from revenue cycle to medical assistants who are faxing papers to providers who wish for intelligent scribing to capture their in-clinic conversations. to prescription refills, which are low cognition tasks. And then, of course, to be successful in value-based care, clinicians, providers are not meant to be coders and shouldn't be expected to do that. And quality measures, which perhaps are a proxy to quality, but an ever-moving goalpost for success. How do we help them achieve performance on that while maintaining most of their attention to the complex patients they needed most?
Mm-hmm. In closing, are you bullish on value-based care?
I am. And to my point earlier, not everybody may be, but it is coming for them. And so this is one of those things where, because the healthcare climate is changing, the incumbents who have had strong market positions may have been able to put their heads in the sand and try to weather the storm. The margin pressures across the board in running our care delivery organizations, in running your supply chain, in the cost of labor, in the cost of pharmaceuticals, in the inpatient needs and the costs associated with those. All of these things are coming together such that I don't think any single person can say, we can keep doing things the way that they are. And so how then do we confront what's to come? There has been some who have been leading the way, and there are some tools that can help you get there. So let's take advantage of being proactive and take that head on and be successful and create a better financial experience and user experience for both our providers and the patients whom they care for.
Well, I want to cheer you on for that. I think really appreciate you coming on the show. It's just a great way to look at the future and say we can make it better.
Thank you for having me, Fred. And I appreciate all your listeners today and the wonderful work that they're doing in each of the corners of the healthcare universe.
Well, thanks again. And back to you, Greg.
And that's a wrap for today's broadcast. A big thank you to our global audience for tuning in, and a special tip of the hat to Dr. David Wang, Executive Vice President of Value-Based Care at IKS Health, for joining us and sharing what it really takes to move from fee-for-service to genuine risk-aligned care delivery. If PopHealth Week resonates with you, do us a favor, subscribe, leave a quick review on your favorite podcast platform, and do share this episode with one colleague who still believes we can build a better healthcare operating system. Remember, PopHealth Week airs on Healthcare Now Radio every weekday at 5:30 a.m., 1:30 p.m., and 9:30 p.m. Eastern. And for West Coast listeners, that's 2:30 a.m., i.e. the night shift, 10:30 a.m., and 6:30 p.m. Pacific. On behalf of Fred Goldstein, the entire crew at Healthcare Now Radio, and me, Greg Masters, stay safe, stay curious, and we'll see you next time on PopHealth Week.